In today's news, we'll be hearing about 3 recent FDA approvals and highlights from the San Antonio Breast Cancer Symposium. Welcome to Enclave News Network. I'm Lauren Ettlinger.
I'm Justin Gallagher.
First in the news, just announced this week, FDA approved lanreotide for the treatment of patients with unresectable, well or moderately differentiated, locally advanced or metastatic gastroenteropancreatic neuroendocrine tumors, also known as GEP-NETs. Already under a priority review schedule, the approval of lanreotide came months earlier than the anticipated March 2015 decision date. The approval was based on the results of the Clarinet trial. According to trial results published in the New England Journal of Medicine, treatment with the somatostatin analog lanreotide significantly improved progression-free survival by 53% compared with placebo for patients with grade 1 or 2 GEP-NETs. Previously used to manage symptoms of NETs, lanreotide is the first and only somatostatin analog to demonstrate a statistically significant improvement in progression-free survival in GEP-NETs in a large multinational study, according to Cynthia Schwalm, President and CEO of Ipsen North America.
Patients with polycythemia vera have reason to celebrate. On December 4, 2014, the FDA approved the JAK1 and JAK2 inhibitor, ruxolitinib, for patients with polycythemia vera who are resistant to or intolerant to hydroxyurea. The approval was based on results from the Phase 3 RESPONSE trial, in which 222 patients with polycythemia vera were randomized to receive either ruxolitinib or best available therapy. Researchers found that ruxolitinib was superior to best available therapy in terms of hematocrit, splenomegaly, and achieving a complete remission. For example, hematocrit control without phlebotomy was achieved in 60% of patients treated with ruxolitinib compared with 20% of patients receiving best available therapy. Additionally, ruxolitinib provided quality of life benefits at both the individual symptom level, including itching and night sweats, and at the aggregate symptom level. Patients in the best available therapy were allowed to cross over to ruxolitinib after 32 weeks. Even these patients receiving this delayed treatment experienced high levels of response, comparable to those who had initially received ruxolitinib. According to Dr. Serdan Verstovsek from MD Anderson Cancer Center, the approval of ruxolitinib represents an important advance for patients with uncontrolled polycythemia vera. For the first time, we are able to provide these patients a treatment that has been shown to provide effective and consistent control of their blood counts and reduce spleen volume.
Patients with advanced non-small cell lung cancer also have a new treatment option. On December 12th, the FDA approved the VEGFR2 inhibitor ramucirumab in combination with docetaxel for the treatment of patients with metastatic non-small cell lung cancer who had disease progression during or following treatment with a platinum-based chemotherapy. The approval is based on findings from the Phase 3 REVEL trial. The international study randomized 1,253 patients with non-squamous and squamous non-small cell lung cancer to receive docetaxel with either ramucirumab or placebo in patients who experienced disease progression after treatment with a platinum-based chemotherapy. Significant improvement were seen in median overall survival, median progressive-free survival, and overall response rate. The most common grade 3 and higher adverse events with ramucirumab were neutropenia, febrile neutropenia, fatigue, leukopenia, and hypertension. Ramucirumab had previously been approved in April 2014 as a single agent and in November 2014 in a combination regimen with paclitaxel to treat patients with advanced gastric cancer or gastroesophageal junction and adenocarcinoma.
And now news on some of the key presentations from the 2014 San Antonio Breast Cancer Symposium. First, in the neoadjuvant setting, nab-paclitaxel proved significantly more effective than conventional solvent-based paclitaxel for patients with high-risk early breast cancer. In the randomized Phase 3 GAPERCEPT2 trial, conducted by the German Breast Group, 38% of patients who received nab-paclitaxel achieved a pathological complete response, or PCR, compared with 29% of patients who received conventional paclitaxel. In addition, nab-paclitaxel also provided benefits to some key subgroups of patients. Notable was the response among the 275 patients with triple-negative disease. The PCR rate among this with nab-paclitaxel was 48.2% compared with 25.7% with conventional paclitaxel. This finding is considered pertinent since there are limited treatment options for triple-negative breast cancer. And according to Dr. Sibylle Leubel, co-chair of the German Breast Group, PCR is most prognostic for outcome in this specific high-risk subtype. There were some differences in toxicity, including a significantly higher incidence of all grades of peripheral sensory neuropathy with nab-paclitaxel. Still, neoadjuvant nab-paclitaxel may provide new hope for the 15% of breast cancer patients which have triple-negative disease.
And there's even more good news for patients with triple-negative breast cancer. The PD-1 inhibitor pembrolizumab demonstrated promising clinical activity with an acceptable safety profile in heavily pretreated patients with recurrent metastatic triple-negative breast cancer. In the phase 1b KEYNOTE-012 trial, treatment with pembrolizumab demonstrated an overall response rate of 18.5% in patients with PD-L1 positive triple-negative breast cancer. Only 15.6% of patients on pembrolizumab experienced grade 3 or 4 toxicities, the most common being anemia, headache, meningitis, aseptic, and pyrexia. According to Dr. Edith Perez from the Mayo Clinic Cancer Center, breast cancer has not typically been found to be a disease that we can target with immune-modulating therapies, which is why it's been explored in other tumors first. Pembrolizumab is FDA approved for patients with unresectable or metastatic melanoma whose disease had progressed after prior therapies. Additionally, it received breakthrough therapy designation as a potential treatment for patients with non-small cell lung cancer. Dr. Perez described her excitement about the opportunities for continued research on how pembrolizumab and other immunotherapies could be used in the setting of breast cancer.
In terms of first-line therapy, there is good news for patients with hormone receptor-positive breast cancer. In the phase 2 FIRST trial, frontline treatment with fulvestrant reduced the risk of death by 30% compared with anastrozole. The median overall survival was significantly higher at 54.1 months with fulvestrant compared with 48.4 months with anastrozole. These results supplement the phase 3 CONFIRM trial findings that showed a second-line treatment benefit from fulvestrant over anastrozole. Dr. John Robertson from the University of Nottingham in the United Kingdom stated that he did not know any other endocrine therapy where you can see a time to progression and survival benefit in both the second and first-line settings. Additionally, the benefit was seen across predefined subgroups of patients by age, tumor size, prior treatments, and other stratification factors.
Expanded results from the phase 3 SOFT trial may change the way that treatment is delivered to premenopausal women with hormone receptor positive breast cancer. Building on SOFT trial results presented at ASCO 2014, which looked at tamoxifen plus ovarian suppression therapy versus tamoxifen alone, patients in a third arm received ovarian suppression therapy along with adjuvant exemestane. Patients in the exemestane arm had a 35% reduction in their risk of recurrence compared with tamoxifen alone. Lead investigator Dr. Prudence Francis from the Peter MacCallum Cancer Center in Melbourne, Australia, noted that the SOFT data were particularly encouraging for very young women, those less than 35, who traditionally have a higher risk of recurrence with hormone-sensitive breast cancers. According to the New England Journal of Medicine article reporting the SOFT results in women who had a sufficient risk of recurrence to warrant adjuvant chemotherapy and who had premenopausal estradiol levels despite chemotherapy, ovarian suppression combined with the tamoxifen reduced the risk of recurrence when compared with tamoxifen alone. Ovarian suppression combined with the exemestane further reduced the risk of recurrence as compared with tamoxifen-based therapy. The researchers also cautioned that even with these promising results, as with most treatments, any benefit from ovarian suppression must be weighed against the possible adverse effects. This has been Enclave News Network. I'm Lauren Ettlinger.
And I'm Justin Gallagher. Thanks for joining us, and happy holidays.